So hello everybody, and thank you so much for having me today for the series of webinars of the World Spinal Cord Society as presenter. I'm going to share with you my experience with transforaminal endoscopic disc surgery. The presentation will be focused on the first steps considerations. So you're going to benefit from if you have done hundreds of transforaminal discs. Probably that presentation will not be very helpful for you, but if you have done below 100 and if you are about to start or you have just started, that probably will be beneficial for you. I have nothing else to disclose. I practice at the minute presently in Belfast. Belfast is in Northern Ireland, which is on the small island here, as you can see, and this all is part of the United Kingdom, and this is the Republic of Ireland. This is the hospital, how it had been before, and this is the hospital, how it is now. This is the medical university where we teach students. We have amazing anatomical facility that we have already organized courses, and we will continue. Hopefully, I will have you soon. So I'm going to start with a few words about the surgery as a concept. As a concept, surgery is you have to follow the steps of the surgery that will allow you to access a lesion that is inside the body. For this, you have to create a surgical path. So you have to split normal tissues in order to achieve your goals, in order to get the surgical target and to do the surgery. And like that, you inevitably destroy normal tissues. Normally, we try to minimize the trauma of the normal tissues, and this is the basic tenet. This is the aim of the minimal invasive surgery, to minimize the trauma for a patient. So I'm going to give you a simple definition of minimal invasive surgery. That's a procedure that results in less collateral tissue damage, measurable decrease of morbidity, faster functional recovery, and still achieving the goals of the conventional surgery. This is a definition that was given by McAfee in 2010, but I still think this is a valid one. I like to start with that. Minimal invasive surgery principles are to use normal anatomical corridors, which you don't need to cut in order to create. You split muscles instead of cutting muscles. You don't disrupt the muscular tendons and attachments of the muscles. So muscles are very important. As you can see from these anatomical slides, there is multiple layer of muscles around your spine, which are the so-called core muscles, which are very important for the functioning of the spine. And that's why we have to pay the necessary respect to these muscles, and that's why we develop minimal invasive surgery. Why we develop minimal invasive surgery? Why we have to make it complicated? This is a question that many people will ask themselves if they have to start. But there is why, because with the minimal invasive, you will significantly reduce your blood loss and pain levels. You will reduce the need of instrumentations. It's cost-effective after you pass the initial stage of developing the surgery. Patients will like it. They ask for it, and it's very popular among the patients. And that will allow you to operate patients that previously you would not consider because of being very obese, have morbidities, high functioning patients as well, which will, the minimal invasive surgery will allow you to operate. There is pitfalls, of course. It's a long learning curve. There is a radiation exposure because you would use a lot of X-ray in order to do different minimal invasive techniques. You need special equipment, and you need to get the proper technique in your hands. everybody speaks about long learning curve, steep learning curve. That's why I just decided, but I'm not sure if all of us understand what exactly and why the learning curve is steep. That slide demonstrates why the learning curve is steep. So as you can see initially, the curve goes horizontal and you achieve your initial experience, but you have to go through all these stages of being novice, being hobbyist, being enthusiast, and finally being expert. So normally you need about 50 cases to achieve a level of initial expertise, but from being from being a relatively unexperienced to become an expert, you need a big number of cases. That's why after the first 50 cases, your expertise will grow a bit slower, and that's why you see the curve is pointed upwards. And that's why we discussed that this is a steep learning curve, because from being a hobbyist to being an expert, you need many more cases than from being a novice to being a hobbyist. So despite the minimal invasive surgery is using different techniques to minimize the access, you have to be aware that despite the minimal invasiveness, that still can give you significant complications. So you have to be considerate about that, and you have to be prepared. So endoscopic discectomies, how to start? Of course, the best way to start a new technique that is complicated is if you can have a fellowship. You can get one of the fellowship programs, but unfortunately they are not available for many of us, or it is too complicated, or you have already well in your practice when you would like to do that, and it's very difficult for you to stop your practice and to be missing from your institution for a long period of time. So let's see if we can have a detour of that, and we can consider different other things, so that can allow us to start endoscopic procedures. Of course, you can attend cadaver courses. Online courses now are quite popular, and we have a lot of webinars happening at present. You can go on a short-term observerships. You can use online resources, and you have option to get also invited faculty surgeons, which will help you with your first cases. That is now provided by many of the companies which are developing the instrumentations for the instruments for the endoscopic surgeries. So if the problem is very complicated, then one of the best strategies is to crack the problem to simple problems. And I'm gonna give you a few words on each of these points. So you have to consider the anatomy, you have to consider the X-ray acquisition techniques, injections. I have put here steroid injections, which are the pain procedures that hopefully many of us do, and that is something that will help you as well. It is good to have previous experience. You have to be very meticulous with patient selection. You have to be very meticulous with your team selection as well. And also, it's good to have somebody to support you in the beginning. If you go step by step with that, you have a good chance that you will be successful with your first cases. But let's see how and why. So we started with anatomy. Of course, anatomy is crucial to understand if you are starting any new technique. And this is the case with the endoscopic transforaminal discectomies as well. Most of us, during our training, we are familiar, we do a lot of microscopic discectomies, and we are familiar with this zone here, which is close midline and close to the midline. And this is the anatomy that we also are possible to expose if we do interlaminar approach, if we do partial hemilaminectomies, if we do laminectomies. We are possible to expose this zone here, and this is where most of the disc herniations are happening. This is about 1/3 of the disc herniations you will find behind the shoulder of the traversing nerve root. And then you can have also disc herniations which are migrated downwards. You can have disc herniations which are migrated upwards. And you can have the so-called far lateral disc herniations. But with this approach, you can access the majority of the disc herniations. Unfortunately, when we are talking about the endoscopic surgeries, we are from the other side of the facet. And I'm saying unfortunately because this is not a standard training. This is not something that we will be exposed so much during our training, and this is why it is difficult for many of us to start this new technique. So you have to consider that you are not only on the other side of the facet, which is, but also the spine will be oriented differently towards you. The spine is oriented in an oblique fashion. And you have to consider that as well when you are starting a preparation for your endoscopic surgeries and when you're familiarizing yourself with the necessary anatomy. So if we go further, we have to comment on the so-called Cambin's triangle, which is the area that was described by Prof. Cambin nearly 30 years ago now. And this is the working area where you will find your disc herniations and where you will work in. As you can see, with the this diagram is showing exactly the location of the Cambin's triangle with respect of the adjacent structures, the nerve root, the inferior and the superior facet. And this is where is your actual working zone. It's close to the disc and it's close to the inferior end plate. So the lower end plate is your best friend, and let's see why this is the case. This is the case because you are by placing your instruments close to the inferior end plate, you are preventing the neural structures. It's a good diagram that is demonstrating that. As you can see, that if your endoscope is docked closer to the inferior end plates, you have good chance to avoid injury of the exiting nerve root. While if you move your instruments closer to the superior end plate, there is a very high chance that you can dock your instruments on the exiting nerve root and cause neural damage. So again, anatomical considerations are important, and you have to be familiar with this before you start planning your surgeries. Image acquisition is another very important thing that you have to be familiar with, and you have to be possible to tell your radiographer to give you the image that you really need. And there is a few simple rules that you have to follow with doing that. True AP and true lateral image. This is crucial when you're doing endoscopic surgeries, because this will be the prerequisite for your proper orientation. What is true AP image? Ideally, when you are working on a specific level, that level should be in the center of your screen, and you should have the end plate of interest as a straight line, but not as it is demonstrated here as elliptical line. This is, if you are meticulous with this, you are having a good chance that you will have good radiological guidance, and that will give you a good chance for successful surgery. So be sure that and make sure that you are acquiring your pictures properly, and make sure that the end plate of interest is a straight line. Another simple rule that you have to follow for a true AP image is that you have to make sure that all the times and with all the pictures, the spinous process is right in the middle between the two pedicles. If you follow these two simple rules, then there is a good chance that your AP will be true AP, and you will have the right guidance. Similar principles when you are when you're getting your lateral images. You see that the true lateral image means that your end plate of interest should be presented as a straight line, but not as elliptical line as demonstrated on the right-hand side. So as you have to have constant 3D orientation, you have to constantly switch between AP and lateral orientation of your image intensifier, and acquisition of good X-rays is of paramount importance for successful completion of your case and for avoiding complications. So that is demonstrated by the following few slides that I'm gonna show you. As the first step of the endoscopic transforaminal surgery is proper docking of your working cannula. The 3D awareness is of paramount importance, and I will show you now why. As you know, if you have attended different courses, you've been taught that the offset of the starting point of your instrument varies as you go up from L5S1 towards the upper lower levels. You can see that this is demonstrated on this slide. You see that at L23, you start from 7 to 9 centimeters offset from the midline. And at L5S1, you can go as lateral as 16 centimeters. This is a good guidance when you're starting your endoscopic surgeries. But with experience and with cases that you will do, you will see that you automatically gauge the line, the distance, and you are not measuring as meticulous as you were doing that in the first cases that you were planning. These are two important lines that you can. I don't measure the offset of the midline in my cases, but I normally aim to be between these two lines. This is the line that connects the top of the process, the line that will connect the top of the facets. If you're between these two lines, you have a very good chance to be following the right have success of your surgery and to avoid complications. So regarding the biplanar 3D awareness, what I mentioned to you is that you have to be constantly aware on AP and lateral where it of your event, and this is demonstrated by these few slides that I have just projected to you, and this is the starting point. All irrespective of the step will be docking of your instrument or needle at the tip of the superior articulating process. And that's demonstrated on the right-hand side of that slide. And on the left-hand side, you have to see that you are just entering ideally just entering or just before entering the foramen. However, if you progress and if you see this picture on AP, that is a good AP picture, but if that is your lateral projection, this is obviously something that should concern you. That is the importance of 3D biplanar awareness, because if you project your trajectory based on the X-rays which you have just seen, that could be a possible trajectory that your instruments are following, and that's obviously something that you don't want. You don't want to have injury of the internal organs. So trajectory is very important, and your 3D awareness is very important for proper docking of your instruments and for avoidance of complications and for performing your surgery. Steroid injections, I have mentioned to you before that the steroid injections are possible to help you with the start of this procedure, if that is something new for you. Before I started my first cases, I have done probably over 100 transforaminal injections following the trajectory of the endoscopic disc surgery, transforaminal disc surgery. And this will be very, very helpful, because like that you are possible to train the trajectory and proper starting point on the skin of the patient, and proper docking of the instrument is a very important first step that will make your surgery later on easier, and respectively very difficult if this is not right. Another benefit from that will be that you will have a good experience, and you will be faster with docking your instrument on the right spot. And this will help you with shortening your intraoperative time. First of the cases that you normally would start doing will be under a local anesthesia, because that is the technique that will give you feedback. And despite of the good anesthetic that you will have, and the anesthetic that will give you good pseudoanalgesia, you still have to be fast enough, because this is docking is a relatively painful procedure. And if you start poking to find the superior articulating facet while the patient is just sedated under local anesthesia, that might give you problems, and the patient may start moving, and you lose your images, and then the surgery can fail very easily. So I strongly recommend you, before you start doing your planning your first patients, try to do steroid injections following the trajectory that you will normally follow for your transforaminal endoscopic surgeries. That will definitely help you. Previous experience definitely will help. If you have endoscopic experience before you start planning your first surgeries, that is something that will be beneficial, definitely. Also, if you have previous experience in the area where you will be doing your endoscopic surgeries, like if you have done before some work in the Cambin's triangle, that will be something that also will help you a lot. Before I started my first endoscopic cases, I already had significant experience, and I had probably over 200 cases done minimal invasive transforaminal surgery, and this was something that was very beneficial for me. Supporting team is very important. If you are starting a new technique, you definitely need a good scrub team that is aware of the instruments and it's aware of the routine, and you don't need to divide your attention to tell them what to do. Anesthetist is very important as well, because, as I said, your first cases will be under pseudoanalgesia, and if you have experienced anesthetists that can give you a good sedation and good pseudoanalgesia, that will be very helpful for the initial cases, which will be inevitably slower and more difficult. Radiographers are also very important. If you are planning to develop this surgery, you probably have to consider working with one and the same radiographer, because the X-ray acquisition is very important. And as I have demonstrated earlier to you, good X-rays and true AP and true lateral that are acquired fast is going to be very important for you. But if your radiographer is new with this technique, and he needs to take many pictures before he gives you the right picture, that will add quite significant amount of intraoperative time. Also, that will give you significant radiation exposure, which is unnecessary. Faculty surgeon is something that you have to consider for your first cases, in case you have not gone to a fellowship and you're not confident with the new technique. Faculty surgeon is now provided by most of the major companies which are developing this instrumentation. So patient selection, what should be the first patient, or the first 20-30 patients that you will consider to operate with this new technique, in case you are just starting. So ideally, this should be a young, fit and slim patient. Ideally, you have to select for your first cases L4, L5, a large extruded disc, which ideally should be paramedian or recessive disc. You should consider a case which has not so much degeneration, and that will give you good foramen width, and that will allow you to place your instruments and still not injuring the exiting nerve root. You have to consider anatomical variations. Sometimes you can see iliac crest quite high, especially with the male individuals, male patients. So you have to be sure that the iliac crest is also not on your way. This is despite L4, L5 regions, sometimes iliac crest can be also very difficult to overcome. So a few words about the possible complications. You can expect to have more complications in the beginning, but you have to make sure that the complications are not major, and this is not because if you have a major complication in the very beginning, that is likely to put you off and to stop developing that surgery. So vascular complications are one of the most significant complications that you can have with the disc surgery. Obviously, with the open surgery, we know that despite it is happening very, very rarely, about 4 to 5 over 100,000 surgeries. This could be devastating, and you can lose your patient. With endoscopic disc surgery, you can almost zero this percentage, and this is something that's one of the reasons why you would consider. There is a few reports though still, but they are only single reports. There is not much reported with respect to vascular injury. There is one report from '89 on sigmoid artery injury. If there is a left iliac vein injury from Kim on 2010, but if you search the literature, there are not many, so this is reassuring. What is prevention of the vascular surgery? Generally, vascular injury. Generally, if your entry point is too medial, and if and then you have chance to your instruments to to the instruments to slide forward and to have vascular injury. That's why you always have to check the position of your needle on lateral and AP image, as I have demonstrated before. You have to consider these two lines. If you're below that red line, you have a very high chance that your trajectory is not right, and you have to correct it. You have to consider also that you may have peritoneal and abdominal injury. Still not many. If you go and see the literature, there is single reports on ureter damage, bowel necrosis. You can have colon perforation and psoas abscess, but still we don't see so many of these even in the large series. This is a picture demonstrating psoas abscess from Escherichia coli, not my complication, luckily. Neural injury. The incidence of open surgery and endoscopic surgery, neural injury is more or less similar. However, it is likely when you start having your surgeries, you can your initial cases, you may have more neural damage, and usually this will be dysesthesia because of irritation of the dorsal root entry of the ganglion. Sorry. So dural injury, again, with the endoscopic surgeries, you can expect less dural injury comparing with the open surgery, but it is not zero, and especially with your first cases, and as you're familiarizing yourself with the technique and with the instruments, you may have a dural injury. The good thing is that even if you have a small dural tear, you can just leave it as it is, and the consequences are minimal, or it will be completely clinically silent. In my initial series, I had small dural tears, and I don't remember needing to go and repair this dural injury. So endoscopic surgery is again favorable with that. Infection, again, anecdotal reports for infection, as I have showed you before. So if you follow the sterility rules, if you're very careful with the use of the C-arm, and if you're considerate about your 3D location, then you can avoid infection injury. If you see your needle accidentally going too anterior, you may be retroperitoneal or even peritoneal, and you may consider changing your needle, and that is good prophylaxis. I mentioned already about the dysesthesis because of the irritation of the ganglion. It's almost always temporal. You may consider temporary. You may consider using steroids to decrease incidence of dysesthesia of your early patients. Instrument fracture is also something that you may have, especially with your initial cases, and this is happening because you're normally very aggressive in the beginning, and you're not familiar with the technique and with the instruments. You have to try to avoid that as well, because this will be bad complications. Residues and large fragments left behind. This is also something that can happen. And in some of the early series, if you check the literature, the reports say up to 1/3 of the patients will have residual and retained disc. Don't jump for early post-operative repeat surgery, because if you leave the patient for a couple of months, the residual may disappear on the follow-up scans. So in case your patient is not symptomatic in the beginning, you may consider watching them in case you leave residual disc. And that was it. Thank you so much.
Thank you, Nikolay, for this very comprehensive and exhaustive overview of transforaminal endoscopic surgery, particularly for giving all these tips and tricks for beginners that I definitely think that should be very useful. So if you agree, in the interest of time, because we have 40 minutes now, so probably we can proceed with the other talk from, and then we do the discussion. Is this okay, Mehmet, or what do you think is best?
Yeah, actually, we can finish this discussion because the two topics are separate.
Different. Topics. Okay.
There are some questions, I think.
Okay. So do you want to make them?
Yeah, please do it.
Okay. So let's see. So one question from Dr. Gibran Tariq, thanking for your presentation, and the question is it possible to remove the intervertebral portion of the affected disc with the transforaminal approach, and if so, how much should be removed? I'm not really, I don't really understand what's the intervertebral, but I think it should be more the midline. I don't know.
Yeah, so I have showed you one slide when it shows how much you can reach. So if it's a midline disc, that is, so your ideal disc to start, it will be paramedian location or recessive location. If it's a medial disc, then that obviously makes it a bit more difficult, and I would not recommend you to start with a case like that. With your first maybe 20, 30, depends on your previous experience, maybe even 50 cases, you have to be very meticulous with your patient selection, and you have to select the easiest case to do. And the easiest case is usually ideally female at level L4, L5, paramedian location or recessive location disc, a disc that is not calcified, the disc that is extruded, and it is easy to remove.
Nikolay, I have two questions. One is that what is the amount of percent of patients that you can use this technique for disc herniation? 30%, 40%, or what?
Right, okay, so that is a very good question, and thank you so much for this, Mehmet. So initially, when you start with your first cases, you're actually quite constrained by the patient selection rules, and this percentage is very small. Actually, it could be as low as maybe 10–20% of all the discs that you see. Just because you're not familiar with, again, you're not familiar with the technique, and you would like to start with easy cases, because if you have a major disaster with one of your first cases, that will be very bad for you, for your self-esteem, that will be very bad in the eyes of your team, and there is a high chance that you will stop doing this procedure, especially having in your hands the microdiscectomy, which is still gold standard and it still works well. And with the microscope, we can do very small incisions now, we can use tubes, and we can do a lot of different things with the microscope. But still, the true endoscopic, the true minimal invasive is the endoscopic procedure. So if you're determined to develop, sorry?
10–20%.
Maybe my initial cases, if I have to calculate, I haven't really calculated exactly, but I would say maybe 10–20% initially. But as you gain experience, you became braver, and you start getting more difficult cases, and this percentage will go up. So the first year, probably the first 50 cases will be 10–20%, but maybe after 100 cases, it might be even more than 30%. If you speak with, I spoke a year ago. Probably I was I remember I was in Greece with Kim from Seoul, and Kim has now probably over 2,000 cases done in his practice. And I've asked him, when did you do open case in your practice? And he said a couple of years ago. So everything depends on your experience and on your learning curve. Initially,
do you ever use some drill to open a part of the foramen?
Yes, I'm introducing this now. But this was not the first thing that I have started with. Okay.
What about L5-S1 level?
L5-S1 level, in case you have low-lying iliac crest, you can consider, but you have to be very selective with L5-S1. Some experienced surgeons are telling me that they are doing L5-S1 in 100% endoscopic, and many of them transforaminal. But you have the interlaminar technique, and I think that, at least in my hands, the L5-S1 works better with the interlaminar endoscopic approach.
Okay. I must tell you that some of my friends have started transforaminal endoscopic discectomy, but then left it because they had some injuries to nerve root, and spinal ganglia, and very, very severe dysesthesias.
Yeah, that's what I said in the beginning.
They left it.
Yeah, this is what you have to try to avoid if you start a new technique. If you're disappointed in the very beginning, you're gonna leave it. You're gonna stop, especially if you have something else. If you have a good alternative like the microdiscectomy. So if you would like to avoid that, you have to be very meticulous with your initial cases, and you should not be rushing to go for complex cases. You have to do maybe 30–40 cases which are really simple, and once you have a good weight of the instruments and good understanding of the anatomy, then you probably can proceed further, and that will allow you to continue without disappointments.
Thank you.
Thank you. And Nikolay, Professor Ben Roitberg is asking you, and I think this is an expected question, that is, how do you compare this to using a matrix tube or a tubular retraction going through the foramen?
Right. So I think that, yeah, well, it's just different tools in your toolbox. It is, if you're using the tubes, that is also good minimal invasive technique that is giving only minimal damage to the surrounding structures, and you're sparing the normal anatomy pretty well with the matrix. However, if you would like to go through minimal invasive, then I think it's a spectrum. Definitely the matrix is on. So if we put the open surgery on one side of the spectrum, and then if we put the endoscopic surgery to the other side of the spectrum, then the matrix tubes are definitely closer to the endoscopic surgery, but not quite there.
Okay. Okay, thank you. So maybe we change to the other topic, and then if needed we can go back. Do you agree, Mehmet?
Okay.
Okay. So as I said at the beginning, next speaker will be Professor Ben Roitberg from Metro Health Medical Center. I think it's Cleveland, Ohio, correct?
Absolutely.
So it's going to talk about laminoplasty.
Wonderful. So, so do you hear me well?
Perfect.
Wonderful. I will share this screen. All right. And can you see me now? Can you see the screen?
Yeah, it's good.
Excellent. So I'll be speaking about doing cervical laminoplasty without hardware. And as we all know, the open door laminoplasty is not new. Introduced by Hirabayashi back in the 70s. And it's a common procedure. Has been reported to be as effective as laminectomy and fusion to treat myelopathy. Between those two procedures, they have largely replaced, for many surgeons, they have replaced regular plain laminectomy. But in the past 20 years, there has been a gradual increase in the use of hardware, plates, screws, and little allografts or a variety of pegs, with increasing cost. However, according to various reviews and also our own study, there is no apparent benefit. We did a study that actually started in my previous institution at the University of Chicago, where I ran a prospective registry. And for a period of time, I was doing routine CAT scans on those patients. So immediately post-op and then at 6 months. I kind of quit doing it, but there happened to be a series that overlapped in time with a prospective randomized prospective registry that allowed us to have a segment of consecutive patients that had not only excellent patient-rated outcome registry, independently collected by a special registry manager, but also CAT scans. So we had an unusually rich amount of information about that series. So that population had 13 females and 19 males, with average age of 66 years. And we performed the procedures during this period, and after that was only follow-up. And most of those patients were, as you can see, older and had many comorbidities, and average BMI was 30. It's not that I selected those patients. Working at hospitals that treat poorer areas in the United States, it usually comes with very high rate of obesity. And patients, many of them were myelopathic, and they were discharged to home or acute rehabilitation. So that was kind of a unique opportunity with a high follow-up rate. The indications were multi-level stenosis, more than 2 levels, or other reasons to avoid anterior approach, and the presence of cervical myelopathy or combination of myelopathy and radiculopathy. Contraindications are fixed or irreducible kyphosis. And of course, the patient needs to be in acceptable medical condition for general anesthesia and positioning. And for the residents or juniors who have joined the presentation, fixed kyphosis doesn't mean the patient is fixed in a kyphotic position. It just means kyphosis that on the flexion or extension X-ray does not reduce into at least straight alignment or hopefully lordosis. So that's irreducible. So my approach was very simple: classical midline posterior incisions, C3 to 7. In this series, I always include the C7. Going only to C6 is also possible, but for some reason, in my experience, the long-term success has not been quite as good. And we dissect muscles to mid-facet and try not to disrupt the facet capsule. Remove spinous processes, preserve C6 and 7 for structural autograft, drill one side, the worst, in the gutter completely, and the other partially until it can bend. This is the finesse of laminoplasty, but it doesn't matter whether you do it with instrumentation or not. Then we create supporting pegs from C6 and C7 and insert them under C4 and C6 respectively. Other levels remain open with the 2 supports. That's an important point. You don't need to put it under every level. As long as there is ligamentum flavum and other tissues between the remaining lamina. And then, important note, I always put the patient in a hard cervical collar for 3 to 4 weeks as muscle support. to prevent early kyphosis and excessive neck pain. It's not for stability for bone effusion, that takes much longer, but really to prevent excessive pain and early kyphosis due to weakening of the muscles. In that study, there were no major complications, no infections, dehiscence, or any graft movement or dislodgement, and specifically no C5 palsy. Again, laminoplasty without hardware is a specialty thing. It's not something that fits all patients. A lot of patients have deformity, kyphosis, and other reasons to do a laminectomy infusion. But with I did more than 200, probably about 230 or 240 cases so far. So it's a little bit of a niche application. But whenever I chose to do laminoplasty in the past, I would say 12 or 13 years, I've done it without hardware, whereas in earlier years, I used to put hardware as various hardware. One dehiscence in a 77-year-old female who eventually was found to have zinc deficiency and had rapid healing with zinc and protein supplements, one infection without dehiscence, and 2 cases of kyphosis progression, one asymptomatic and one with severe chronic neck pain that was not relieved by fusion. Both of the patients at lower doses were borderline indications, and also did not, one of them did not cooperate with wearing a collar. But at this time, I would have fused them rather than go with laminoplasty without fusion. Here is an example of a CT scan 1 day post-op. Axial at C6. Well, that's on the left side. On the right side, it's 6 months post-op. Exactly same patient, exactly same cut. So what we can see is that this autograft integrates very nicely. This kind of smooth contour of the fusion is typical of this type of PEG autograft. It remodels to fit the patient's topology, which you cannot see, of course, with allografts, with dead cadaver bone or anything else. In that study, we could see the gradual improvement of visual analog scale follow-up scores for neck pain, which is quite impressive. NDI, PCS, that's the SF36 PCS scores, but the mental did not change. Mental remains the same. We also have a perceived outcome in which here it is. That's a better thing. So we have the early perceived outcome was it was actually a patient questionnaire that asked them how are they doing compared to before surgery. Overall, their overall condition. And in the first evaluation at 3 months, everybody was happy, had at least some improvement. And then at 1 year, you can see that some people had worsening, significant or very significant worsening, but the majority still perceive that they are much better than they were before, or at least somewhat better. So it's a kind of a 7-point scale of change in their condition. Numeric scores also improved, and the main conclusion is that cervical laminoplasty without hardware can be a successful treatment for cervical myelopathy and radiculopathy. I have some observations to share. Is first of all, the patients experience an improvement in their pain score on the VAS, including neck pain. The results of the VAS for neck pain are better than what has been reported in the literature for open door laminoplasty procedures. And they observed an average improvement of 1.15 points on the VAS of neck pain. And I think, I speculate that early use of a collar has contributed to that. Improvement in neck pain is not a goal of laminoplasty or any decompressive surgery for myelopathy. It's not something we necessarily expect, but it's a good bonus. Our patients had an improvement in neck pain despite not performing a muscle-sparing dissection. And the VAS was decreasing over time. Performing laminoplasty without allograft and hardware saves on cost of the procedure, without apparent detriment to the outcome of the patients. I do not believe that laminoplasty with hardware, with plates and screws, would prevent poor late outcome due to kyphosis. So you just need to watch very carefully what the indications are. The mechanical part, the biomechanical part of the laminoplasty is the same. It is a laminoplasty. The question is, of course, the placement of little plates and screws that were not available in the first generation, the first 25 years, were not done, and then became very popular, and I claim for no particular medical reasons. The rate of fusion at the second scan, usually at 6 months postoperatively, in that series was 100%. And again, I'm hard pressed to continue after that to subject every patient to a CAT scan. So I usually do just an X-ray or flexion extension X-ray at this time because fusion has been a very high rate. And again, it's hard to justify the cost and the radiation of repeat CAT scans routinely for those patients. And you can see an open canal pretty well on a regular X-ray in those patients. And there were no reclosures. And that's one of the first questions. You didn't put any hardware, wouldn't it reclose? And the answer, no, it doesn't. So basically, that's it. Thank you very much.
Thank you. Thank you very, very, very much for this presentation. And I always listen with great interest to lectures on spine surgery without implants, given the growing trend towards more complex surgeries and more expensive implants. That if this is a problem in developed countries, I think it's even a much bigger problem in underdeveloped countries with scarce resources. And in fact, even personally, we do our most common posterior cervical spine surgery is laminectomy, and we don't really face. I think selection is a key issue, but on patients that we do laminectomies, we don't see really problems like it's written everywhere about kyphosis and things like that. My question regarding is your technique is that how skillful do you think it is the carpentry to adjust the spinal process to the gap without putting any kind of mini plate or whatever?
Sorry, I will ask, do you have displacements after this? If you don't.
No, and I think that there was also a little note here in the chat. A trick to put the graft and avoid the misplacement would be appreciated, please. And I think that's what a lot of people are asking. The trick really is when you are doing the drilling on one side for any open door laminoplasty, is the hinge side should be drilled carefully and just enough to bend it. It's green stick, and you just enough to bend it, and not to overbend it until it completely breaks. Even then, it's usually okay, but that's one trick. The other trick is just make when you take the spinous process, you make it into something that's about and you adjust it to the size of the opening and the patient. You make it in something that's about 1.5 centimeter wide, maybe 1 centimeter wide at C6 and one at C4 and 1.5 centimeter wide at C6, and create little troughs. Now the spinous process has the top and the part that attaches to the lamina. The part that attaches to the lamina goes on the facet. The wider part that is at the top goes on the lamina on top. That usually is the better geometry to prevent it from kind of pushing down on the nerve root or anything else. And you made a trough that's not too huge. The trough needs to be maybe 2-3 millimeters deep at the bottom part, and that's about it. If you look at it, just look at it and think how it should look in order to fit really well. And then you just slide it very carefully into place. And at that point, if you did not break the lamina completely, it will just sit there. And the interesting part is, if you think about the anatomy and the movements after you're done with the patient and stitched everything back, there is no movement that will dislodge it. The muscles, if they contract, will press down, which increases stability. Since the graft sits between the lamina and the facet of the same level, there is no movement of the neck that dislodges them. They move as a unit, so you don't see dislocation. I had a patient. One of the things that convinced me to not even try to do laminoplasty with hardware are two cases. One is a dislodgement of an allograft that caused a radiculopathy in a patient and required me to go back and remove that thing, right? So I had a complication with an allograft. And number two, I had a patient who was an elderly patient, about 80 years old, and whom I did this laminoplasty without hardware, who fell, didn't have a collar on, didn't have anything, got up, was attached by sequential compression devices to his bed, took a step and a half and fell and hit his head and snapped it backwards to the point that he had a large gash on his forehead and had to be stitched by the resident on call. We did a CAT scan afterwards, perfect alignment, nothing. So that convinced me. It was I commiserated with the patient, but I also thanked him. So thank you very much. You've demonstrated something to me. I really appreciate it. I'm so sorry that you had to go through this, but it was an amazing thing. So that's kind of, these are the tricks.
Yeah, thank you. Thank you very
thank you, really. I will ask one question from, I will direct one question from Dr. Selin Bozda from Izmir. She is asking, does resection of the spinous process cause the loss of the posterior tension band? And in the long term, it may cause some kyphosis.
Very good question, and something that has been a very difficult issue for me, because some of the posterior tension band is, of course, between the spinous processes. However, if the spinous processes, when you tilt them for the opening of the posterior laminoplasty, are at a very strange angle, and the muscle attachment is actually quite disturbed if you keep them. So that's a theoretical basis for why maybe keeping the spinous process is not ideal. Number two, they are the absolutely best source of autograft, and it's a balance. They are the absolutely best source of autograft. I think that using the spinous process has been the key for success for me and for those who are now not that many, but used to be many more in the 80s and 90s who use this technique. And I think that if the muscles reattach to the bone, then it's fine. I've been using it. This is not part of the published data in the 2017 neurosurgery article, which is mostly what I cite in this talk. But it's data that I've been accumulating since. I usually bring patients back in for a flexion and extension X-ray. They are losing a little bit of mobility over time, so it's not absolutely fusion free, and I do not know why that is happening. But they do not have the progressive kyphosis if they did not have it to begin with. So I think if you are really looking for indication, do it only in the patients who have at least a little bit of preserved lordosis on flexion extension. If they can even a little bit extend their neck on the flexion extension X-ray, you're probably safe. But if not, then yes, the laminoplasty is not that different from a laminectomy, and the posterior tension band that remains is not enough. It is enough if you have lordosis. If you already have kyphosis, it's not enough.
Yeah. Another question from Dr. George Salazar is asking, during this 6-month period until fusion takes, what is the danger of instability injury?
I have not seen a single event in which a patient had any trouble. I recommend people who are working hard physical labor to not return to full duty. So fortunately, it's not a very common issue at this age. The majority of the patients are older and do not work hard physical labor. I just tell them, don't lift more than 10 pounds with each arm. Don't do something, very aggressive or intense. That's all. And now I'm talking about my total experience with them. Not just the particular series. That has not been a problem.
Okay. Ben,
it's the first 3-4 weeks that they have a lot of neck pain. That's an issue.
I myself would like to ask you, what is your policy for OPLL cases? Do you still use laminoplasty or make laminectomy plus fusion?
I have done. First of all, the incidence of OPLL in my population is low. Of the past 200 cases that I kept record for, the OPLL were a handful. Really, it's mostly the usual in my part of the world, degenerative disc disease, the degenerative facet disease. I've had some patients with rheumatoid arthritis, and I have about the same number with rheumatoid arthritis as I had with OPLL. So with OPLL, I just used them with the same indications. If they are not kyphotic, I did laminoplasty, and that was okay. But I don't think my experience really counts much compared to those who see it routinely.
Recent trend is that because of new publications from Japanese papers, if you make a laminoplasty, OPLL may continue progression. Because of that, if you are doing a multiple level decompression, it's better to make it a laminectomy plus fusion in the younger patients, but you can still do laminoplasty in older patients. There is such a trend now.
I would trust the people who do it all the time. Again, my population is much older, and they see the OPLL in the spectrum of ages. So I would trust what they say.
I think Dr. Atul was with us. Atul is here. We can unmute him and then ask his point, because he's for using a fusion surgery only without any decompression in all OPLL cases.
But it's very interesting.
What do you think about this, Ben?
Oh, well, it depends on whether the patient already has myelopathy and the severity of the myelopathy. I have a tendency to, worry about not decompressing a myelopathy. If the patient has some milder symptoms, some radiculopathy, you could chance it and do only fusion, but you're already operating. So I always decompress. If the patient has myelopathy, I decompress them. And then fuse, again, a very large part of my practice, I do fuse. So it's because they have deformities and instability, and laminoplasty is not adequate. The decompression, all my allopathic patients have so far decompressed.
Okay.
So let's just let me go back to the carpentry issue. So in the side of that opens, so you use the notch of the spinal process to put the graft in the lamina. But on the other side, in the transition between the lamina and the facet, how do you prevent it from moving? How do you prevent your graft? You do another notch, or
right. So there is one side is the complete trough that you drilled all the way, and then you know removed the ligamentum flavus. The other side you drill a trough. I usually put just a little bit of graft, enough to fill that little gutters that to slightly accelerate, hopefully, that fusion. I do not pack it. I was trained, you know, back in the mid-90s when I learned this procedure from Dr. Frank Wagner. It was just pack it. And I think that the majority of surgeons in those days were taught to just pack it, like you do for a fusion. And I think that when you really overpack it, you create a lot of fusion. And I saw some reports that really the immobilization after laminoplasty was the same and as quick and as solid as after laminectomy with fusion at 1 year or 2 years. I have not seen that. I do have, when you do flexion extension X-ray after the laminoplasty, the way I do it, you do see mobility. It's with the years it gradually decreases, but you do see mobility. It's not the same as doing laminoplasty, laminectomy fusion. And that's because I don't pack lots of graft. It's an instinct that we all have as spine surgeons who do fusion, is to pack the graft really well and have a good graft and pack it, you know, massively. But that's, in this case, it's probably excessive and may actually contribute to fusion. You don't want to fuse the levels to the next. Just, you know, I think that even if you put no graft on the other side, it will heal because it's not completely broken.
Okay. So thank you very much for these two presentations that I think they have been really very helpful and it's and very educational because they included a lot of tips and tricks, and I think this is a key issue for us. So we don't want to have these webinars saying the things that you can see in every paper or every book chapter. Thank you for joining us. So Mehmet?
Actually, there is one more question from participants asking, sometimes we do partial facetectomy with laminectomy, then what you do?
For me, if the question is for me, for laminoplasty without stabilization, I mean, you could do probably a tiny little bit of facetectomy, but I think if you're truly going to have a significant amount of facetectomy at several levels, and you know, if you need to do a very extensive amount of facetectomy or foraminotomy, in those cases, I'm a little concerned about you know, not fusing. I would fuse. If you do, I mean, it's a judgment call, but the more facetectomy you do, the less stable the patient will be. And in the laminoplasty, the technique that I like is to prevent, to not even disrupt the capsule if possible, to not cause more additional instability than you have.
I think this could be a better question if the question was, are you able to make foraminatomies in laminoplasty cases?
Yes, you can.
In laminectomy cases, we do always make it.
Right. So yes, you can. On the side, usually it's very easy on the side of the hinge when it's open. It's possible in the selected cases to do that on the contralateral side with the trough, as long as you don't, you know, remove too much of it. And I've done this. I've done it in, you know, 10–15% of laminoplasties. I also do significant foraminotomies. Again, I believe that if your main problem and it's dominant with radiculopathy and you have significant radiculopathies, it's a judgment call. It's possible. Yes, I've done laminoplasty with foraminotomy, but it always, the judgment of what to do afterward, whether to just leave it as a laminoplasty, it depends on how much you need to how many levels, how much you need to do. A single level foraminotomy, even on the side of the hinge, not the open side, is feasible.
Okay.
Okay, so we have the polling questions here that have been being shown by now I think we all can see them, can see those. Correct. So I think those were the questions made by you. Ben, do you want to comment the results, please?
Absolutely. So if you can scroll, I don't think I can scroll. So the first question is, yes, fixed kyphosis is the contraindication. Accentuated cervical lordosis is not. All of the above is. The correct answer is fixed kyphosis, as most people said.
Okay. So let's move to the second question. Imad, please.
Yes. So indeed, the answer is to allow for muscle healing in lordotic position. It's not prevent graft mobility, because to allow fusion, and that's a really important thing. And it's not eliminate risk of chronic neck pain. The key here is the word eliminate. So those who answered A and D are incorrect, and that's really an important. That's a very, very good clarification. It does not. The heart collar is not done to prevent graft mobility, because if it were to prevent graft mobility, the patient would need a heart collar not for 3 weeks, but for several months. Graft mobility is limited by the biomechanical nature of the construct. It doesn't tend to fall apart naturally. That's why you don't need hardware. And the main reason is to allow for muscle healing in a neutral lordotic position to prevent neck pain and to prevent some impetus for early impetus for kyphosis. And the D is to eliminate the risk of chronic neck pain. Again, those who put A and D, nothing eliminates the risk of chronic neck pain. Indeed, in our series, we had some decrease in neck pain compared to preoperative condition, which I think was a very nice success. I'm very happy about that. But it doesn't eliminate chronic neck pain. There's no surgery can eliminate chronic neck pain.
But Ben, don't you think that using a heart collar can really cause some muscle atrophy, and at the end to contribute to chronic back pain? Or
absolutely, that's why it's only 3 weeks or so.
Okay.
Absolutely. That's why I never wanted to continue for longer. The rationale for 3-4 weeks is that's about the time that it takes for the muscles to reattach. At this point, you need to stop and remove it, because once the muscle are reattached and some of the neck pain decreases, patients, you can see how patients can now kind of pretty freely move the neck after about 3-4 weeks. And that's empirical, based on observation of patients and reading of the biology of muscle healing. So that combination is okay. In some patients, 4 weeks if it still hurts, then you do not have atrophy, you're fine. But if you keep it for 3 months, absolutely, that would be a serious problem.
Okay, and so probably this relates to the next question, right?
Yes. That's a
Can you move downward?
If you can move it. Yes. So absolutely. Correct. The majority of the responders were correct. Heart collar for 3 to 4 weeks. May remove to sleep after the first week, because again, this is not for graft stability. It's to make it easier for a patient to keep their neck in an upright, neutral, slightly lordotic position as the muscles heal. That's the trick. And I think that this trick is actually the main difference between my practice and what I read in the early times in the 80s and 90s. It's a cheat code for this game. Next.
Okay, and then fourth question. Can we move downwards, please?
Yes. So exactly. I wrote the questions like I do for residence exams. So they are tricky multiple choice questions. And the answer is B. No graft dislocation was observed in 32 consecutive patients for whom postoperative CAT scan was available. This is the report. This is the data. That's the published data. I do not know maybe they move slightly in between and wiggle, but on the scan a day after surgery, on the scan 6 months post-surgery, they're in the same position, just fused. That's the data we have. And I haven't had since 2006, when I fully moved to doing laminoplasty without hardware, I have not had a single clinical event of graft dislodgement. Sir, let me just move it a little bit because I think I don't see my own answers. I just want to minimize this screen. Okay, here it is. So are we now on question 5? Could you move it up a little bit?
Yeah. Can we do that, team up, please?
Yes, excellent. So structural.
The fifth one.
The answer is A. So because you don't see the whole answer here. In the grafts are placed at C6, C4, and C6. If you do C3 to 7, and in minimal morcellite grafts are placed in the contralateral drill troughs. Yes, okay. That's the correct one because you don't need, as we discussed in the question and answer, you don't need a lot of graft there. So the rest of available autograft, which is answer B, is I believe incorrect because you may enhance fusion, accelerate fusion between the levels, and in this case you don't need to fuse C4 to C5, only the ring of C4 or the ring of C5 or the ring of C6. You don't really need to fuse between the levels. So as the most of the responders answered correctly, you put the pegs at C4 and C6 and a little bit of graft on the other side.
Okay, perfect. So this closes the polling questions. I don't know if we have anything left. Mehmet, Salman, Nikolay. Okay, so we are done. I don't know if Imad has already the slide for the next webinar.
No, sir, it's not ready yet right now.
Okay, okay. So we will send this through email as usually.
Yes, sir.
Thank all of you for joining, and if you have any suggestion or any topic you would like to be covered here, so please send us an email, and we look forward to incorporate them in these webinars.
Thank you, Ben. Thank you, Nikolay.
Thank you very much.
Goodbye.
Thank you. Thank you very much.